prior decisions by the United States Supreme Court have made clear that the state has a constitutional responsibility to provide adequate medical care to inmates in state prisons. In 2006, after finding that the state had failed in this duty, a federal court took control from the Department of Corrections and Rehabilitation and assigned the responsibility for managing the inmate medical care program to a federal court-appointed receiver. Since that time, the current and prior receivers have implemented a number of policy changes with the intent of improving the quality of inmate medical care. It appears that the actions they've taken have been successful in some respects, and the Office of the Inspector General has been auditing the quality of the inmate medical care provided to inmates over the past several years, and those audits have shown that nearly all of the state's prisons have increased in the percentage of policies and procedures that they are adhering to. However, it does appear that the increase in the quality of care has come at a very significant cost. And since the beginning of the receivership in 2005-06, costs have increased dramatically. And from the time the first receiver was appointed in 2005-06 to 2008-09, we saw the cost of the inmate medical program increase nearly double, in fact, from about $1.1 billion and to almost about $2 billion 3 years later. In recent years, we have seen a trend towards decreasing costs, which we think is encouraging. However, we're still spending at this time about 40% more than we were spending at the beginning of the receivership on the inmate medical program. In addition, it appears that we're actually spending more than what other states are spending in this area as well. A recent survey found that most states are spending between about $4,000 and $7,000 for inmate health care, and California is actually spending about $14,000 per inmate per year to provide similar services. There are a variety of reasons why we're spending more than what other states are spending. We have identified several areas where we think there are unexploited opportunities to reduce costs in our system. For example, the receiver uses a system to determine when inmates should be referred to outside hospitals to receive specialty care. It's called the Utilization Management system. And while that system has been successful at reducing the number of costly referrals to outside care, we find that it's being applied inconsistently among the state's 33 prisons. In addition, the receiver uses telemedicine, which is audiovisual technology used to connect inmates in a state prison to physicians located sometimes hundreds of miles away remotely. This can increase both access to care as well as decrease the costs associated with transporting an inmate to an outside appointment. We find that there has been an increase in telemedicine, but we're still not fully exploiting as a state the opportunities to reduce costs by using that technology. And finally, we think that the current administrative structure is inefficient because the receiver maintains his own set of administrative staff separate from CDCR to undertake such functions as budgeting, accounting, and IT. This past January, the federal court overseeing the inmate medical care program found that while some improvements are still needed, the state has made significant strides in improving the quality of inmate care. As a result, the court ordered that the parties involved in the litigation related to medical care, including the receiver, the administration, and the attorneys representing the inmates, get together and produce a plan for transitioning control of the inmate medical care program back to the state. Thus, we think that in the near future, the legislature will be faced with some critical decisions about how to deliver inmate care sustainably at a constitutional level after the receivership has ended. While the end of the receivership is now in sight, it is likely that the court will continue to have some type of oversight role even after the receivership during a transition period when the court is assessing how well the state can deliver a constitutional level of care without the receiver in place. In determining how to transition control of the inmate medical care program from the receivership back to state control, we think there are a couple of keys to long-term success that the state should be focused on. First of all, it's important, we think, to establish some type of ongoing independent oversight and evaluation of the system. In addition, we think it's important to control inmate medical care costs. Based on our review of California's inmate medical program, as well as our review of experiences in other states, we are recommending that the legislature create an independent oversight board that could fulfill this role of providing ongoing independent oversight and periodic evaluation of the inmate medical care program. We think this would have a couple of advantages. First of all, we think that it would demonstrate to the federal court that the state has established some system for credibly providing ongoing oversight of the program, and this should help to facilitate the end of the court's oversight of our inmate medical program by demonstrating that without the court there looking over the state's shoulder, we can continue to provide a high level, constitutional level of inmate medical care. In addition, we think that given CDCR's very poor track record in delivering inmate health care services, that having some type of independent oversight can be an early indicator when enough care could potentially backslide following the end of the receivership. Having this ongoing independent periodic evaluation of the system would allow the state to identify if the care did start to deteriorate so that it could take remedial actions to improve the quality of care before we're in a situation where we're at risk of additional litigation related to the quality of medical care. In terms of addressing the cost of the inmate medical care program, we recommend that the state take immediate actions in the near term to address some of the unexploited opportunities for cost savings that we identify in the report. However, we don't think this will be sufficient alone to bring the cost of the inmate medical care program to a level consistent with what other states are spending. In order to do that, we think there would probably be we would need to make a more fundamental change to the way we approach delivering inmate medical care. As such, we are recommending that the state explore a pilot contract with one or more managed care organizations who could provide comprehensive inmate medical care, including primary and specialty care to inmates in our prisons. In our view, this would introduce competition into the program and would incentivize the adoption of additional cost efficiencies. And doing this on a pilot basis would allow the state to evaluate what the impact on quality and the cost of care is of those types of contracts.